Yeah, I think we thought actually the two of us together that it was about time that pediatrician treating sJIA and adult rheumatologists treating adult-onset Still disease would actually merge together their view, their perspective, their understanding, their evidences to reach a number of conclusions that could be joined between the two categories.
And I think it was really something that was needed for pediatricians, but also for adult rheumatologists. And it will probably facilitate the conduction of studies, of clinical studies, to improve the management of the problem. So we did it with a group of pediatricians and adult rheumatologists who were pretty numerous, almost 30 people. We had also patient representatives and young investigators. We did literature searches on how to make the diagnosis, on the comparison between the expression of the disease in adults and children, about macrophage activation syndrome, about biomarkers that help physicians to make the diagnosis, and also about the treatment. And based on that, so we had two live meetings, one to really focus the work, the second one to interpret the data to the literature. And finally, we achieved a group of recommendation for the diagnosis of the disease, also for the treatment.
So the first things we actually defined was the name. We eventually agreed with a large consensus that it was actually one disease across all ages, that age matters a little bit because there might be different features or manifestation according to age, but eventually that we needed one single name, and we agreed on going back to Still's disease.
Absolutely. A major progress, it may have an impact in terms of level of the medication, but I think it's important to consider the two diseases as the same. The second thing was about the treatment, how to monitor the patient. So here we don't have a clear and common tool for children and adults, maybe it will arrive in the coming years, but we know how to identify what is the treatment objective, and we define it as a clinically inactive disease, a situation in which we have no symptoms of disease, no CRP increase, so no marker. We also achieve what we call intermediate target, which is very important at the beginning of the treatment. We want to achieve a very rapid response in terms of fever improvement or resolution, in terms of decrease of CRP, then after a few weeks to be able to see a reduction in current symptoms, with no fever, with a low dose of corticosteroids. And so we have this very tight schedule to achieve the clinically inactive disease that we want to achieve. At 3 months, the glucocorticoids should be at a very low dose, and at 6 months, glucocorticoids have to be stopped. So it's really a very ambitious way of managing the patient.
We have now powerful IL-1 and IL-6 inhibitors. We collected high-level evidence on the efficacy of these drugs, together with a lot of real-life data suggesting that they work. We agreed on a treatment algorithm that would actually allow to guide you to achieve those targets that Bruno was alluding to as fast as you can. Remembering that getting clinically inactive disease is doable in the great majority of the patient rather rapidly, I may say so, in a few weeks or a few months, and getting rid of glucocorticoids is actually one of the most important targets that we should achieve because of the relevance of glucocorticoids for comorbidity in adults, for slowing growth in children, so really we want to get rid of the glucocorticoids.
It's a very also important message that we achieved to make is to recommend to use very early this very efficient treatment, IL-1 or IL-6 blockers, because we have in mind the evidence in the literature is not as perfect as a randomized controlled trial, but several observational studies indicate that when you start this treatment very early, you're able to achieve in a higher percentage of patients clinically inactive disease, and we really think it may also reduce the prevalence of chronic active disease. It may be chronic articular disease or relapsing disease. So we really think that the earlier we treat the treatment, the most efficient will be with the therapy. and at the end it will be possible for to migrate maybe for all patients to achieve clinically inactive disease lasting for many months, then remission, with treatment, and then without treatment, which is the ultimate goal of our management.
And one last thing, the task force recognized that there are very difficult patients. They are difficult to treat patients, those with chronic or relapsing acute MAS, those who have lung disease, and even more rare complication, and these are part of the research agenda because we need to understand in greater detail the pathogenic pathway and possibly identify targeted treatment for these patients as well.
So I think we covered the full spectrum of our work, and we'll continue to develop common tools and common ways of managing the patient. I think it will be very important, and it will also increase our possibility to do research on the various